Hey, future doctors! Welcome back to another high-yield USMLE case. I'm excited to walk through this challenging pediatric scenario with you today. By the end of this video, you'll master one of the most testable lysosomal storage diseases. Let's dive right in. Picture this. An 8-month-old infant comes to your clinic. The parents are worried because their baby has lost developmental milestones, shows an exaggerated startle response to sound, and during your eye exam, you notice something striking. A cherry red spot on the macula. The head is enlarged, but here's the key detail. The liver and spleen are completely normal in size. Now take a moment to think, Metas, what substance is most likely accumulating in this patient's neurons? Let's work through each option systematically. First, galactocerebroside. This accumulates in Crab disease, which is indeed a lysosomal storage disorder causing progressive neurodegeneration. But here's the catch. Affected infants typically develop optic atrophy, not the bright cherry red fovea we're seeing here. So this doesn't fit our clinical picture. Next, glucocerebroside. This accumulates in Gaucher disease, another lysosomal storage disorder. Gaucher disease typically presents with bone pain and hepatosplenomegaly. But wait, our patient has a normal abdominal examination and that distinctive bright red fovea. This makes Gaucher disease highly unlikely.
What about heparin sulfate? This accumulates in mucopolysaccharidosis like Hurler syndrome. These patients do show neurocognitive decline and coarse facial features, but they also develop significant hepatosplenomegaly. Since our patient has normal liver and spleen size, this doesn't match either. Now, sphingomyelin. This accumulates in Niemann-Pick disease, which does cause neurodegeneration and cherry red macular spots. However, patients with Niemann-Pick disease typically present with hepatosplenomegaly. And we know that's not present in our case. So what's left? GM2 ganglioside. And this is where everything clicks into place. Tay-Sachs disease is an autosomal recessive disorder caused by beta-hexosaminidase A deficiency. This enzyme deficiency results in lysosomal accumulation of GM2 ganglioside, which is a glycolipid component of cell membranes.
The key clinical features that make this diagnosis unmistakable include progressive neurodegeneration with developmental regression, an exaggerated startle reflex, and that pathognomonic cherry red macular spot. But here's the high-yield point that separates Tay-Sachs from other lysosomal storage diseases. The distinguishing feature is normal liver and spleen size with macrocephaly. This is absolutely crucial for your exam. Let me repeat this high-yield concept because it's so testable. Tay-Sachs disease presents with neurodegeneration, cherry red spots, and normal hepatosplenomegaly. Remember this triad. It's pure gold for step 1. The pathophysiology is straightforward. Beta-hexosaminidase A deficiency leads to GM2 ganglioside accumulation in neuronal lysosomes. This toxic buildup progressively destroys neurons, explaining the devastating neurological decline we observe clinically. Once again, the key distinguishing features: GM2 ganglioside accumulation, normal liver and spleen size, progressive neurodegeneration, exaggerated startle response, and that unmistakable cherry red macular spot. So the correct answer is C, GM2 ganglioside. This case perfectly demonstrates why understanding the biochemical basis of lysosomal storage diseases is so important for step 1. Each disease has its own unique accumulating substance and clinical presentation pattern. Thank you for watching. If this video helped clarify lysosomal storage diseases for you, please like and subscribe for more high-yield USMLE content. Remember, mastering these biochemical pathways now will serve you well, not just on step 1, but throughout your medical career. Keep studying hard, and I'll see you in the next video.